Assalamu alaikum and hello to all of you. Before starting the program, let's praise Allah. For that, I would like to call Mr. Atayib Tal Irfan for recitation.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت ربنا لا تؤاخذنا إن نسينا أو أخطأنا ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين صدق الله العظيم.
MashaAllah and Jazakallah Tayyib. Good morning, ladies and gentlemen. It gives an immense pleasure to be a moderator of such a huge event. Like always, Indus Hospital and Health Network has managed to provide knowledge and services for the country beyond the call of duty. It is well spoken. Going far beyond that call of duty, doing more than the other except. This is what excellence is all about. It comes from striving, looking after smallest details, and going extra miles. With this slogan, I, Qasim Raza, Senior Physiotherapist at Indus Hospital and Health Network, would like to dedicate these words to the person whom I'm going to invite. A man who have worked beyond his duties throughout his entire life. Please welcome Director of Rehabilitation and Head of the Department Trauma and Orthopedics at Indus Hospital and Health Network, Professor Dr. Muhammad Amin Chunai, to address us a few words and grant us permission to begin the program. Dr. Amin, please.
Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome everybody to the ICON 2022. It is a great pleasure to be able to welcome you all here. I am very humbled and I acknowledge the great support that has been given in the organization of this program by the head chief of our rehab services at Karachi campus, Umair, our manager, Siddique Sahab, and our head of the physiotherapy at Karachi campus, Dr. Farah Naz. All these three have worked very hard to put together a very robust program, which you are all going to attend and hear. The important thing is here to mention here is that this is not only a program of the Karachi campus. All the campuses, especially in this session, all the four campuses of four rehab centers coming under the umbrella of the Indus Health and Hospital and Health Network, i.e. Karachi, Badin, Muzaffargarh, and Lahore, are also participating. In this regard, it is very, very important to acknowledge and thank our partner, the International Committee for the Red Cross, ICRC, and the representative, Mr. Nasir, who is going to speak on this occasion as well. Without much further ado, I think I should let the scientific program continue, and I hope that you enjoy this program there's something for everybody to learn, and there should be very important takeaway messages here. Thank you very much.
Thank you, Dr. Amin, for your kind words. Thank you, Dr. Amin. Let's continue the program. When I am willing to do the right things, I am rewarded with an inner peace. No amount of liquid would overprovide when I'm unwilling to do the right things. I become restless, irritable, and discomfort. It is always our choice. Just like that, COVID 19 left no choice for everyone. But with the passage of the time, we all fought and stood together. And now we have a choice to get vaccinated. Hope everyone is vaccinated. Physiotherapists have also actively played a vital role as a first line of defense. With that, I would like to call Mr. Qasim Raza to talk about the role of physical therapy interventions in the management of COVID 19. Mr. Qasim Raza.
I am Qasim Raza, Senior Physiotherapist, Indus Hospital and Health Network. As we all know, we are gathered here for the ICON 2022. And in this session, I'm here to represent the role of physical therapy intervention in the management of COVID-19. As we all know, the COVID-19 is a deadly virus that's led to the global disaster affected on the countries in terms of health, economy, social, and the personal life. This is transmitted through the respiratory secretions of the infected humans. There are the several symptoms, which includes the fever, cough, fatigue, sputum production, and the shortness of breath, which can lead to the moderate to the severe COVID pneumonia possibly. Let's talk about the physiotherapy, which plays a vital role in the treatment, in the rehabilitation of the COVID-19. If we talk about the goals of the physiotherapy in the respiratory disease, there are the several goals which we can achieve by doing the by doing the executive physiotherapy in all of the respiratory disease. The first one is the improved lung function. It's basically improve and helps in the lung functions to regain the normal lungs volume. Second, decrease the patient's dependency. Number third, it's improve residual lung function. The fourth one, it limits patient morbidity and mortality. Also help in contributing the optimize ventilation and oxygenation supply. Basically, it improves the oxygenation supply and reduce the ventilation ratio. Sixth one, reduce number of hospitalization stay. It also helps in reduce the complications, which include the hospital acquired complications and several others. And the last one is to improve the quality of life. In short, at all, basically it helps in the improvement of the quality of life the patients. If you talk about the indications of the COVID-19 patients regarding the physiotherapy interventions, so the first one is the suspected or the confirmed COVID-19 patients develop moderate or severe pneumonia. The second one is mucus hypersecretions / difficulty in clearing secretions. If the patient had some kind of difficulty in clearing the secretions, so that is the purely indication of physiotherapy after the COVID-19. Patients with associated pulmonary diseases. There are the several pulmonary diseases like COPD, chronic obstructive pulmonary disease, ILD, bronchiectasis, cystic fibrosis, and etc. In all these pulmonary diseases, it helps actually in regain the normal life. Fraction of inspired oxygen, FiO2 less than 60 degree, in percentage it's 0.6%. Saturation, that SpO2 is greater than 90 degree. If we can start the physiotherapy if saturation stay as 90 degree or above, and after doing the physiotherapy, it improves usually. Respiratory rate is less than 40 breath per minute. Systolic blood pressure, BP, greater than 90 degree and less than 180 degree mmHg. The heart rate, it's greater than 40 bpm and less than 120 bpm. This is the pictorial form of the COVID-19 patients, which we are doing physiotherapy in a COVID unit. We'll discuss about in future in the next slides what actually happens in these pictures. If you talk about the contraindications of physiotherapy and rehabilitation and interventions of the COVID-19, it's actually a dry or totally a non-productive cough, and which we have to be very conscious regarding the rehabilitation. The lower respiratory tract involvement, which usually involves pneumonitis rather than the exudative consolidations. That is contraindicated actually. High intensity of fatigue and intolerance of physical activity of the patient. Maintenance, recovery of the activities of the daily living are in the acute phase. If patients come in the acute phase, so we have to mostly focus on the other respiratory conditions, and rather than to improve his daily activities or maintenance of his. After a few days, when patient go through the subacute phase, then we can work on his daily activities living. The patient is anxious if arrhythmia or the myocardial ischemia, which is the contraindication. Systolic blood pressure is greater than 180 mmHg. Blood oxygen saturation is less than 90 degree or drop greater than 4% from the baseline, which is standard. Respiratory rate greater than 40 breaths per minute. Yes, let's talk about the physiotherapy interventions. Physiotherapy interventions, the first one and the very important, the infection control precautions. As the COVID-19 patients, in the COVID-19 patient, we have to follow the precautions. In infection control precaution, first performing the hand hygiene, and after the hand hygiene, we have to wearing of the PPE, the personal protective equipments. That includes the gowns, that includes the N95 masks, especially, then the head cover, then the shoe cover, then the sheet, face sheet also included on these. And after all these, perform the hand hygiene before entering the room of the specific patient. Then the maintenance and the recovery of the activities of daily living are contraindicated in acute phase. If you talk about the acute phase, the activities of daily living are mostly contraindicated, or its maintenance, or it's, we can start the working on the ideas after a few days. Chest physiotherapy, which is very important and has a vital role in COVID-19 rehabilitation, that is divided into the passive chest physiotherapy and the active chest physiotherapy. And if we talk about the passive chest physiotherapy, we can do by the manual method as shown in the picture in the slide. This is the passive manual percussion method of a COVID-19 patient for the expectoration of the sputum to release out from the airways. And there's other method which is called the mechanical method by doing the percussor machine also, and the second thing, high velocity frequency wave oscillation machine, which we'll discuss in the future slides. If we talk about the next steps, the physiotherapy, the chest physiotherapy also do in the form of active chest physiotherapy. Active chest physiotherapy actually includes the ACBTs. ACBTs is active cycle of breathing techniques and incentive spirometer. Active cycle of breathing techniques, it's a set of breathing exercises that loosen and move the sputum from your airways. And in these techniques, the exercises includes are the breathing control, the deep breathing exercises, huffing or FETS, means forced expiratory techniques. We all do these exercise in a patient, or encourage him to do these exercise to remove the secretions or the sputum from your airways. The next is the incentive spirometer. It's a device actually which patient can do by himself and to improve the lung capacity, improve the airflow from the lungs. There's a pictorial forms of the COVID-19 patient in a COVID unit. Patient is doing active chest physiotherapy techniques, that is the ACBTs, active circular breathing techniques, the deep breathing exercises with IDTs, the interditic techniques patients can do by him or himself. Furthermore, there are several positions of the patients which we make during the hospital stay. Therapeutic positioning, which are very important in supine lying patient. Then patient in transfer to the lateral side, or it's maybe right lateral or the left lateral. Then the prone lying position, very helpful in COVID patients to regain the normal lungs capacity, the normal lungs volume. And the posterior drainage. Posterior drainage basically is the position of the patient with an involved lung segment into the central airways, where it can be removed via huffing or coughing techniques. And the benefits, actually, the posterior drainage give us, it's minimize the risk of chest infections, and it's improve the respiratory functions. We almost do the posterior drainage in COVID-19 patient and other respiratory disease too. Early mobilization in ergonomics. Early mobilization has a good role in COVID-19 patient. We have to mobilize the patient from sitting to standing, then standing to further progress. And ergonomically, patient how is sitting, how is transferring from bed to chair, then and how is sitting for prolonged time. We have to maintain the, or we have to get it from the bed sore and pressure sore. So that's why the ergonomically patient has to be very good. Therapeutic range of motion exercises. Therapeutic range of motion exercises that improves actually the joint range of motion, which can be done passively and actively and active assistedly. Passively, a therapist or the external force applied on the patient to move his or her limb. Then active, the patient is able to do exercises by himself, and active assisted, there is a little assistance from the therapist, or and there is a effort from the patient too in doing these range of motion exercises, which basically improve the joint range of motion, flexibility, and improve the muscle work. Progress to the strengthening exercise in post-COVID event. As patient is getting better day by day, we can improve to the next stage of exercises, which we call the strengthening exercises or the resisted exercises, and post-COVID rehabilitation. After discharge from the hospital, the patient is able to come in the rehabilitation unit for post-COVID rehabilitation, where patient is doing the furthermore gym exercises, improve the cord drills, the cycling, and the treadmill, and etc., the pulley and all these exercises. Exercise prescription depends on the muscle power, functional independency, respiratory functions, hemodynamic function, and oxygen dependency. On all these factors, the exercise prescription basically has a choice to be depend on these factors. Intensity of exercise should not be hard, leading to high breathing effort. Exercise frequency once to twice a day, duration 14 to 45 minutes per session. Here is the pictorial form of the patient who is doing active exercises, as was discussed in the last slide, the therapeutic exercise range of motion to improve the joint range of motion. This patient is do by himself, and in the picture downward on the right side, a therapist is giving assistance. He's able to move his limbs doing the exercises. The next slide is about the high frequency chest wall oscillator, HFCWO. This is actually a mechanical device, or we can say that which we have to do in the passive chest physiotherapy. A high frequency chest wall oscillator, it's an airway clearance techniques. One more thing, it can be self-administered to in a patients, but normally a therapist or some other person apply on the patients. Basically, this techniques produce the vibrations at variable frequencies and intensities to break up the mucus which is in the patient lungs and make it thinner, so it will remove from the lungs easily. Creates mini cuffs in the lungs, like a patient has a long cuff, a big cuff, so it creates the variable frequencies, produce vibration at several intensities to break or creates the mini cuff in the lungs, which helps push the mucus out. makes the cilia move faster, helping them carry the loosened mucus to the upper airways. It actually helps the mucus which is inside or the lower tract to move and move the cilia faster so it can come to the upper airways. This is actually how it works. This is the percussion pictorial view. You can see from the front and from the back too. Here we can apply it's the jacket. There's the remote control. It's the vest which we have to wear on the patient's chest wall. Front side on the back side. It produces continuous vibration and at different frequencies and levels. These are the vibrations, vibratory effects. Vibratory effects actually helps to break up the mucus and make it thinner and thinner so it can easily expel out from the patient's lungs. This is the drainage view which we do from the upper lobe, middle, lower lobe. This how it's counting. It's from the front and it's the back side. 1, 2, 3. How it works. Thank you.
Thank you, Mr. Qasim Raza, for sharing your knowledge related to the management of COVID-19. As the COVID-19 pandemic continues to impact Pakistan also like globally, and as hospital and health network gather resources so that you can stay calm and connected in this icon. I would like to call Dr. Farooq Rathore, who is a consultant and associate professor in rehabilitation medicine at the Armed Force Institute of Rehabilitation Medicine, Rawalpindi. He is an active researcher with 160 publications and 70 oral presentations at the national and international conferences. He will share his views about COVID 19, a window of opportunity for rehabilitation professions. Dr. Farooq Azam.
Here. I'm Dr. Farooq Rathore, working as an associate professor and consultant at the Armed Forces Institute of Rehabilitation Medicine, Rawalpindi. And today I'm going to talk about how this tragedy of long COVID can be a window of opportunity for rehabilitation professionals all around the globe and particularly in Pakistan. Before I start off, I would like to clarify what do I mean by rehabilitation professionals. By rehabilitation professionals, I mean the multidisciplinary team of rehabilitation professionals that comes from a diverse background. That includes rehabilitation medicine professionals, that includes physiatrists, physical therapists, occupational therapists, prosthetists and orthotists, speech and language pathologists, and other important members of the team. COVID-19 was a truly global healthcare crisis. This pandemic so far has resulted in more than 278 million confirmed cases and more than 53 million deaths. It has also been estimated that around 253 million have recovered. But the question is, have they truly recovered? Literature in the last 1.5 years now shows that there's an entity known as long COVID or chronic COVID, in which the patient might become negative for COVID 19. They might not have any symptoms, they might not have any blood test positive for COVID 19, but they are not well. They are not back into life. They have something that they cannot explain. They have something that health professionals cannot understand. And this is what makes long COVID. Long COVID has been named as many entities: chronic COVID, post acute sequelae of COVID 19, post COVID syndrome, long term COVID, persistent COVID 19 syndrome, and long haulers. All of these words have been used in context of long COVID in the last 18 months. The question is, what is long COVID? A couple of months back, there was a confusion that how do we define long COVID? But now World Health Organization has provided at least a basic preliminary definition of long COVID that makes it easier for us to understand what long COVID-19 is all about. And it is a condition which occurs in the individual with a confirmed history of probable or confirmed SARS-CoV-2 virus infection, usually 3 months from the onset of COVID-19, with symptoms that persist for at least 2 months and cannot be explained by an alternative diagnosis. This is what long COVID-19 latest definition by World Health Organization is. Long COVID is a very diverse thing. Research is being done and we still have literature coming in. One of the most important article that I considered was a systematic review and meta-analysis which was published a couple of months back, and it documented 50 different kind of long-term effects of COVID-19. So this means that long COVID is not a single entity. It's a diverse symptomatology which can present in different ways. And the eye cannot see what the mind doesn't know. So if you don't have any idea, any information about long COVID, you will not be able to pick up that entity and you will not be able to provide any service. The common symptoms so far that have been documented in literature are tiredness, dyspnea, fatigue, and brain fogginess, which mean cognitive dysfunction, and the person is unable to concentrate on work and at home. It also includes chronic headache, a persistent loss of smell or taste, which makes it difficult a person to enjoy food or go out or socialize or interact with people. Cough, depression, and low grade fever, which are not explained by any other medical etiology. Palpitation, dizziness, muscle pains, aches, and joint pains. And many of these patients, at least I know personally, are ending up with rheumatologists and other colleagues in orthopedic. And they are undergoing a long list of tests for rheumatoid arthritis and other form of reactive arthritis. And all of the tests are coming out to be negative. But unfortunately, these patients are not getting better. This is what long COVID looks like. In addition, all of these are not going to kill the patient, but they are going to result in a compromised mobility, reduced socialization, and a poor quality of life for the person having long COVID 19. Long COVID was initially not picked up by healthcare professionals. We need to be very cognitive of this fact and we need to understand that. Initially, it came out in different news media outlets and things like Newsweek. And these were some of the headlines that came out in the literature. For example, COVID-19 patient symptom can last for months after first they appear. COVID-19 patient, even mild cases of COVID-19 are taking months to recover and suffering extreme fatigue. And meet the long haulers, a growing chorus of Corona-19 patients who are having symptoms for more than 100 days. So it started appearing in literature more than 1 year back, but it took the medical fraternity around 1 year to understand that there's something called long COVID, and this needs to be understood and addressed. This was a great write-up which was published in Atlantic, which clearly showed that COVID-19 can last for several months. And this is what we call long haulers. And I'm going to share with you some patient narratives. For example, look at this. Fiona Lowenstein, one of a US writers, says, "It almost feels like I have been hit by a truck at 4 p.m. each day." 4 p.m. is middle of the day. Imagine someone getting crippled at 4 p.m. How he or she is going to live through rest of the day. And look what Paul Gorner, the professor of infectious disease at the Liverpool School of Tropical Medicine, has to say. "I have had dengue, I have had malaria. I have been never as ill as this. And it's been really frightening because it's so unpredictable. It's the worst illness I've ever had. I'm still dealing with exhaustion." Exhaustion is not something that you can see or document like diabetes or hypertension or pulse rate. It is something very sort of like personal. It is something that cannot be expressed, but it is something that actually puts a patient in a position where he or she is unable to do the work that they want to do. So we need to understand that long COVID is a reality. Dr. Robert Glatter, emergency physician from New York City, says, "We really have to pay attention now. The COVID-19 has created these long haulers. People who go through this for months get really anxious and frustrated and depressed, and they don't know how long they keep fighting." So we need to understand that these patients with long COVID-19 are also frustrated because they are not getting the physical and emotional support from healthcare professionals that they want. This is a very important study that was published a couple of months back, and it was actually a global survey and international cohort, 7 months of symptom and their impact. So the important thing is that there were more than 3,500 respondents from around 56 countries, including Pakistan. And in these responded, the time to recovery, they said that the time to recovery can exceed 35 weeks. Now, 35 weeks is actually more than 9 months. In these patients, all the tests were negative, but the person was not getting better. And these patients with long COVID, they reported prolonged multi-system involvement involving everything that I've just documented, including the neurological system, the musculoskeletal system, and the pulmonary system. And this resulted in a significant disability affecting their mobility and quality of life. And by 7 months, many patients were not yet recovered, mainly for systematic and neurological cognitive symptom. And most of them had not returned to their previous level of work, and they continued to experience significant symptom burden in their daily, personal, and professional life. So this is what like long COVID or chronic COVID looks like. And these long haulers are fighting for their future because many healthcare professionals do not understand the etiology and do not understand the impact of burden of the disability on these patients who have so-called recovered from acute COVID-19 infection. So some consideration for long COVID-19 are: number one, there is no correlation between the severity of acute COVID-19 and the long-term symptom of long COVID. So a person can have a very mild acute COVID-19 and can end up with very severe long COVID, or the person might have acute severe infection with COVID-19 but might have a very mild form of long COVID. So this had to be considered that there is no correlation between severity and symptom. Number two, young people can also have long COVID 19. You need to understand that. Unfortunately, in this country, there's a major challenge that, once young people come with aches and pains and joint issues, अक्सर लोगों का क्या होता है, तुम तो जवान हो, तुम्हें ये दर्द कहाँ से हो गई है? We need to understand that we need to be considerate. Anybody can have problem, and even young people who are having acute COVID-19 can end up with this fatigue, cognitive dysfunction, and other things. This long COVID-19 has been documented more common in female because of many issues. And unfortunately, there's an issue of medical sexism as well, in which you tend to disregard the complaints of a female just because they are females. अरे आप तो खातून हैं, आप तो कंप्लेंट करती ही रहती हैं. We do not need to do things. And therefore, I can say journal, and in particular in Pakistan, is unrecognized, neglected, ignored, or even dismissed by physicians. This global tragedy, a pandemic of COVID-19, a window of opportunity for rehabilitation professionals. And for this, I would take you back to earthquake 2005 of October 2005. October 2005 earthquake was one of the most devastating tragedies in the history of Pakistan. It was a natural disaster, which resulted in hundreds of patients having amputation, peripheral nerve injuries, and specifically spinal cord injuries. It was a tragedy that left in its wake tears. It was a tragedy where we did not have enough beds to manage these patients with spinal cord injuries. And these patients with long bone fractures and spinal cord injury had to be managed in makeshift centers like these. So what happened? What was happening? Acute care was being provided, but there was no provision for rehabilitation of these hundreds of patients with amputation and spinal cord injuries. And there were a huge number of these patients, more than 700 traumatic spinal cord injuries and more than 1100 documentation cases of amputations. There was no integrated plan for care after acute surgical management. There were very few and poorly equipped rehabilitation facilities available in twin cities of Islamabad and Rawalpindi. And therefore, the rehabilitation professionals, that is, physicians, physical therapists, occupational therapists, and orthotists, they rose to the challenge. And they actually provided services and documented their experience and shared data all around the globe. And it resulted in people coming to Pakistan to help out people with disabilities. And this resulted in a very positive outcome for rehabilitation sciences. We got the recognition that we required, and people understood that why it is important to integrate a rehabilitation system along with acute care. Acute care can save life, but rehabilitation can integrate that person back into life, which is as important as saving life. So that's why, as rehabilitation professionals, as physiatrists, rehab physicians, as physical therapists, occupational therapists, and other rehabilitation professionals, you need to understand how can you contribute. So first of all, you have to be proactive. Unfortunately, still in Pakistan, people are not involving rehabilitation professionals in the acute COVID-19 management. You need to be proactive, and you need to tell your colleagues in internal medicine, pulmonology, and other specialties that how integrating acute rehabilitation in acute COVID-19 can improve the long-term outcome of these patients. Number two, you should be educating others. The eye cannot see what the mind doesn't know. People are not trained in rehabilitation. They don't know what rehabilitation is all about. You need to be proactive. You need to take the literature to them and tell them how integrating rehabilitation is going to improve the outcome, as documented by many studies from China, Japan, Europe, and Northern America. And you need to understand, in the middle of difficulty lies opportunity. If October 2005 earthquake was an opportunity for rehabilitation professionals, this is also an opportunity for us. So look at this. People are publishing different things. For example, you can create a prospective surveillance model for use by physical therapists. So look at this beautiful model. You can go online. It's available free of cost. So how can you change your physical therapy services in response to long COVID-19 or acute COVID-19? So look at this, what people are doing. They are changing their system, and they're sharing their experiences of providing services in these challenging times with the wider world. You can also do that. Look at this. Like if the patient has symptom, what to do. If you don't have symptom, what to do. The general assessment, treatment orientation, and different things. And you focus on the cardiorespiratory, neuromuscular, and mental health of the patient. So do things, document them, and then share with the wider world. Apart from that, please try to document your experiences. You're working in Pakistan. You have a very different healthcare system, which is totally different from what is available in the West, in the Europe and Northern America. You have difficulties, you have challenges. Please document them and try to generate evidence by documenting this experience and analyzing it statistically by valid tools. And please remember that so far, even after 2 years, things are not clear in black and white. There are many questions that need to be answered, and there are many confusions that need to be addressed. And that's why every contribution from every part of the world matters. So, while generating evidence, what you can do, you can either write data-based articles, like, for example, epidemiology and clinical features of long COVID of the patient that come to you. You can actually document the role of rehabilitation interventions by maybe doing randomized or non-randomized or quasi-experimental controlled trials on different interventions. And then you can document outcomes in two groups: the group that was given rehabilitation interventions and the group that was not provided early integrated rehabilitation services. And you can write a data-based article on these outcomes as well. And obviously, as rehabilitation professionals, it's your job to offer long-term follow-up to these patients. No disrespect to my colleagues in acute medicine, but unfortunately, they do not follow up their patient for long. They are mostly concerned with the acute outcome. जान बच के अल्लाह का शुक्र है मरीज को घर भेज दें. The long outcome is actually the baby or the responsibility of a rehabilitation professionals. So do that and document it. Apart from that, you can write in any format, in anything. For example, you can write letter to the editors. You can share your perspectives, personal views, point of views, observations, editorials, commentaries, mini reviews, special communication, and brief report. So much can be done by a rehabilitation professionals in context of providing service to long COVID. So coming to the last part, the call for action, what you should be doing. This is a sort of a plan, a work plan that I would like to give to my colleagues working in rehabilitation in Pakistan in particular and in the world in general. First of all, please yourself learn about long COVID-19 and the adverse impact on patients' quality of life, mobility, and community reintegration. If you yourself are not clear about long COVID-19, I'm sorry, you are not going to teach others. Then you have to educate others, and especially people in acute healthcare, about what long COVID is all about and how it can impact the patient's life. You can hold lectures in your institutions, you can do hands-on workshop, or maybe some training session. Apart from that, please start providing services to these long COVID-19 patients. And for that, first of all, you have to recognize the patient at risk or the patient who are having long COVID-19. And then you have to provide them integrated early multidisciplinary rehabilitation services as per their need. If possible, please try to establish specialized services focusing specifically on long COVID-19. And then you have to document the work that you are doing and you have to share it with the wider world. And probably you can make a positive difference in these patients' life and also in your own professional life as well. So the take-home message is this stuff of long COVID is real. People are ill. Doctors need to stop diagnosing this as anxiety. We have messed up before. Let's not do it again with long-term COVID-19 illness. So thank you very much for giving me this opportunity again. If you have any question, feel free to email me or explore my channels for further information. So thank you very much. Assalamu alaikum.
Thank you very much, Dr. Farooq Azam, for this detailed presentation regarding the COVID-19. I hope it will help for all the rehabilitation professionals in the future too. Now, I would like to invite Dr. Mr. Farrukh Siddique, who has devoted 12 years of his life to develop a well-equipped and organized physical therapy department at Indus Hospital and Health Network. He talked about several topics on different occasions in the icon previously. Moreover, he successfully developed Indus College of Physical Therapy and Rehabilitation Science and working as a vice principal over there. Now, I would like to call Mr. Farooq Siddique to share your views about steps to overcome challenges in Doctor of Physical Therapy education. Please, Mr. Farooq Siddique.
I am a vice principal in Indus College of Physical Therapy and Rehabilitation, which actually comes under the umbrella of Indus University of Health Sciences or Indus Hospital and Health Network. Well, today I'm discussing the issues or challenges in Doctor of Physical Therapy education. So, first of all, I would like to talk about educational institutes or universities. and they actually plays an important role in training experts of various disciplines needed in the society. So in current academic era, the experience of both educators and students of all disciplines is of vital importance. So carrying this vision greatly influences the level of education in universities or in especially DPT colleges. So now I would like to draw your attention on the challenges actually we have faced or we are facing in Doctor of Physical Therapy education. So here are the barriers. First of all, I would like to draw your attention towards personal and professional characteristics of clinical educators. These are generally they are actually generally responsible for facilitating the acquisition of profession-specific skills by a student during the practical sessions and on all field training. So during this time, the relationship between the clinical educator and student is considered as a fundamental part to the success of clinical training program. So here are the barriers from clinical educators, which are actually lack of responsibility of a clinical trainer and insufficient clinical skill level of a trainer. So secondly, personal and professional characteristics of students. Clinical education is an important component of physical therapy education. So clinically, education is equally important, and the efficiency of clinical education requires a common understanding of the long-term complication involved in addressing the existing barriers. So these are the barriers from the student side, which are a lack of students' discipline, inadequate participation of students in education, and lack of students' practical knowledge. And the third one is inefficient educational system. So inefficient educational system consists of following subcategories. These are inadequate theoretical and practical training, lack of training supervision, and unsuitable training environment, lack of specific curriculum or educational approach, poor management of clinical training programs, and poor teaching and learning strategies, and assessment criteria, which are lacking in continuous assessment during the studies. So it is very necessary for the students to be well prepared in terms of theoretical courses, which in turn are extremely important for preparing them for clinical education too. So fourth one is educational costs. This is one challenge that is not going away anytime soon. So it is actually difficult for students to focus on their studies and career, and it's not a concern that affects only physical therapists, but it's worth nothing that physical therapists usually have at least 5 years of college behind before they start work in the professional career, and that actually brings lower salaries than the most of other healthcare professionals. So this is the major issue. And the fifth one is the last one I'm actually highlighting here, which is a very important, and it's actually can be resolved on emergency basis. That is curriculum integration. So I would like to define curriculum integration first. It refers to combining two or more subjects when teaching a topic. So it actually involves integrating the subject concepts and subject content and the subject competencies, which are skills we have to develop in a single topic. So it actually motivates our students, and it will lead to deeper learning, and curriculum integration also aligns with the current trend of teachers working cooperatively in shared innovative learning spaces with large group of students working independently. So how to overcome these challenges? So in my opinion, or I can say after my analysis, I think students' academic self-perception, atmosphere, and learning perception are main factors which are actually affecting the educational environment at the physical therapy institution, especially in Pakistan. So first of all, I think we have to work on DPT curriculum, which is Doctor of Physical Therapy HSC curriculum. We should follow thematic approach to design our DPT curriculum, which is actually quite commonly used in MBBS and other curriculums of medical education. And after that, we have to develop a conceptual basis approach towards the curriculum. And the other thing is, which is required on urgent basis, that is like student-centered approaches are more effective than the teacher-centered approaches. So to promote a positive educational environment, we have to apply student-centered approaches more. So I would like now to introduce my college, which is Indus College of Physical Therapy and Rehabilitation. And I told you it comes under Indus University of Health Sciences, or Indus Hospital and Health Network project. So we are here actually dedicated to the proper growth and development of every student for a better career prospect. And we are trying to provide full support to improve students' communication skills and critical thinking. And critical thinking abilities to inculcate the sense of responsibility. So here is a picture attached of the presently we are actually teaching here in Honor Foundation. And secondly, I would like to talk about curriculum integration here. What we have done in Indus College of Physical Therapy. We have tried hard to apply a thematic approach to the presenting DPT HSC approved curriculum. And we are having a small window, or you can say a limitation of HSC approved curriculum, and we had to work under some limitations. So we are actually trying hard to make this curriculum a better theme-based curriculum. So these are actually the strategies we are following in teaching and learning. Number one, large group interactive lectures, small group discussions or tutorials, and lab and practical based sessions we are doing in ICPR, and case-based discussions, clinical skill sessions we are doing. Hospital and clinical visits we are actually offering from the very beginning of the program. And e-learning is very important nowadays. So we are actually providing all the e-learning facility to our students, and self-directed study also. And assessment methods we are following, which are BCQs, OSPE, objective structure, practical examination, objective structure, clinical examination, which is OSCE, and quizzes and presentations, small group discussions, structured vivas, and clinical skills performance. So that's all from my side. I just wanted to highlight this issue, which is actually presenting in our educational system, especially in physical therapy. So thank you so much, all of you. Special thanks to Indus Hospital and Health Network for organizing such conference and providing us a platform to highlight or to discuss these challenges in educational system of physiotherapy education. Thank you very much.
Thank you, Mr. Farooq Siddique, for highlighting the challenges in the Doctor of Physical Therapy education. And I hope after your presentation, it will help for the current student and the students who want to enroll in the future Doctor of Physical Therapy education. Once again, thank you very much. Our next speaker is Dr. Farah, who is the head of physical therapy services at Indus Hospital and Health Network. She acquired Pulmonary Rehabilitation Training Program from Lung Foundation Australia in 2018. She have also acquired online respiratory COVID-19 update sessions in the year 2021. I would like to call Dr. Farah to deliver us regarding the showcase of Physiotherapy Department of Indus Hospital and Health Network. Dr. Farah.
And I'm heading physical therapy services at Indus Hospital and Health Network. And today I will brief you the showcase of physical therapy department of Indus Hospital and Health Network. So Indus Hospital and Health Network is one of the hospitals in Pakistan providing free of cost multidisciplinary rehabilitation services under one roof, including physical therapy services, prosthetic and orthotics, psychological therapy, speech and audiology. The physical therapy department is committed to ensure free of cost, highest possible level of services in the outpatient services and inpatient services, and that include male and female pain management, OPD, functional electrical stimulation, along with free of cost conveyance services. And functional electrical stimulation machine is used for the neuro rehab and pulmonary rehabilitation, along with the conveyance service, home-based pulmonary rehabilitation program, amputee rehabilitation, post-COVID rehabilitation, gynecological and obstetric rehabilitation. And in inpatient services, we are providing our services in intensive care unit in peds and adult, in highly dependency unit in peds and adult as well, and coronary care unit, peds ward, general and oncology, in orthopedic and trauma, and we are providing our services in general surgery and allied surgery as well, in medicine and pulmonology, gynecological and obstetric ward, and COVID ward, including COVID emergency. These are the pictorial presentation that are showing the physical therapy services that are being provided in this hospital and health network. Functional electrical stimulation. This is the machine that is used for neurologically impaired patients, and it is patterned electrical stimulation of neural tissues. It restores and enhances a lost or diminished functions. This is the machine of restorative therapy, FES system that provides safe and effective treatment for weak and paralyzed muscle. It improves ADLs and quality of life, for example, standing, walking, reaching, and grasping. Electrical stimulation actually causes the muscle contraction by innervating the muscles. This is the pictorial presentation of electrical stimulation, and the picture is showing the electrode placement on different muscles, and the tablet that is showing the electrical stimulation of FES machine. Indication for FES machine is a stroke, traumatic brain injury, spinal cord injury, multiple sclerosis. It also can be used in Parkinson's disease and cerebral palsy. In some conditions, FES machine is contraindicated, like cardiac disease, any cardiac disease, and the patients who have pacemakers, in critical respiratory disease, the patients who have exercise-induced illness, and in fixed contracture where range of motions are limited, and in severe osteoporosis, and the patients with bed sores, and in acute fracture fixations. For example, if patient has any implant in lower limb or the area where we need to apply the FES machine. So after the selection of the patient from the given criteria, we assess the patients by following the different phases. For example, patients' detailed history, medical, social, and surgical. Presenting complaint, reflexes, muscle power are measured, and range of motion is documented. And after that, realistic goal is set so that we can achieve that goal in after some sessions, or after the 100 sessions at least. So, functional electrical stimulation clinic, this was established in 2016 in this hospital and health network in Korangi campus. Free of cost conveyance service was also started in 2019 after when the patients was dropping out due to affordability issues, so that they can complete their treatment sessions. So this service was also started in 2019, and now the dropout rate is decreased a lot. So from the 2016 till now, we have enrolled 128 patients and 48 of them have completed their treatment sessions. And in the recent year, we have given the 1300 sessions to the neurologically impaired patients from July 2020 to June 2021, along with the free of cost transport service. This is the pictorial presentation of FPS conveyance service. So the next is amputee rehabilitation. Amputee rehabilitation, the rehabilitation after limb loss to ambulate successfully and to perform the activities of daily living and to return to a normal or the normal social reintegration with the use of prosthesis. A role of physical therapist in physical rehabilitation process. The physiotherapist plays an important role in the assessment, prescription of exercises, and in pre-prosthetic treatment, for example, strengthening of the stem and maintaining the residual limb or joint range of motion, and in bandaging, scar mobilization, desensitization of the stem, some strengthening exercises, and pain management. And in physical therapist plays an important role in the involvement of first fitting of the device. And the main role is in gait training and involvement of checkout device and device delivery. This is the pictorial presentation of bandaging techniques for transtibial and transfemoral amputations. Gait training. The pre-gait training is very important, and that works on balance and coordination, orientation to the center of gravity and base of support. It includes single limb standing, gait training skills, sound limb and prosthetic limb training, pelvic motions, and variations. And in advanced gait training, we works on multi-directional turns, including backward and forward walking, side stepping, straight line walk, stair climbing, uneven surface ramps and hills, and in single limb squatting, transtibial. It is done in transtibial and not in transfemoral. Running skills, recreational activities, for example, cycling, treadmill, and how to come back on their jobs. These are the pictorial presentation of advanced gait training, in which we work on squatting and floor sitting. 4,779 free of cost physical therapy sessions have been given to make the amputated patients walk again, to make them independent, active, and productive member of society. Pulmonary and post-COVID rehabilitation. Pulmonary and post-COVID rehabilitation is evidence-based, multidisciplinary, comprehensive intervention. It educates the patients regarding their disease, symptoms, and how to control their symptoms, and reduce hospitalization and revisits. It improves quality of life and make the patient independent and confident. Indication and the patients who have breathlessness due to moderate to severe chronic obstructive pulmonary disease, for example, COPD, bronchiectasis, patients who are with post-COVID sequelae, chronic respiratory diseases. In assessment procedure, assessment and reassessment are done on every first and 18th session of the program, and intermittent assessment is also done on 10th and 12th session of the program. Assessment includes the breathlessness scale, that is modified medical research council scale, to measure the breathlessness, and 6-minute walk test, COPD assessment test score, and it also includes St. George respiratory questionnaire form that includes different portions, that symptom scores and activity scores and impact scores, and mental health screening and patient feedback form. And we also monitor the oxygen saturation and heart rate while assessing and reassessing the patient. This is the pictorial presentation of pulmonary rehabilitation program, some of the pictures. Till now, we have completed the patients with post-TB sequelae and bronchiectasis, then their number is 41, and with COPD and asthma 51, and other respiratory disease, for example, ILD and other chronic respiratory disease are 16, and with post-COVID-19 patients. This is the graphical representation of MRC scale that shows the breathlessness, and it improves from 3.02 to 0.98. 0 is actually normal and 4 is severely breathless. The average improvement in the patient in 100 patients showing this graph. Walking distance in 6-minute walk test. So the initially 189 was the distance, and after 18 sessions, it improves to 293 meters. And this is the graphical, pictorial presentation of pulmonary rehab convent service. The next is gynecological and obstetric rehabilitation. So the role of physiotherapy in gynecology and obstetric is to strengthen the muscles and in the preparation of labor, abdominal, pelvic floor, and back muscle strengthening, relief in back pain. It improves circulation. The physiotherapy increases flexibility in these patients, and it increases and maintain aerobic endurance, increases energy level and less fatigue. It improves posture and appearance. The contraindications for gynecological and obstetric rehabilitations are with the patients with serious heart, lung, kidney, and thyroid disease, poorly controlled diabetes, history of miscarriages, premature labor during the pregnancy, very high or very low blood pressure, acute infectious disease, and rehabilitation is also contraindicated in ruptured membrane, placenta previa after 26 weeks. And these are some postural guidelines that we taught to the patients how to sit properly or stand, and the proper sideline positions, and how to lift the weight from the floor in proper position. So the exercises that are being taught during the antenatal period in first trimester, second and third trimester are circulatory exercises of upper limb and lower limb, stretching exercises of arms and legs, breathing exercises, back stretching and strengthening exercises, neck exercises, abdominal exercises, and pelvic tilting. And pelvic floor exercises are the main and important exercises, for example, Kegel exercise. And these are the pictorial presentation of antenatal activities. Thank you.
Thank you, Dr. Farah, for this great overview about the showcase of physiotherapy department at Indus Hospital and Health Network. Next to our speaker is Mr. Abdul Nasir, who is the prosthetist and orthotist at International Committee of Red Cross ICRC, Islamabad, for give us knowledge regarding the multidisciplinary team role in physical rehabilitation. Mr. Abdul Nasir. Yes, Mr. Abdul Nasir, please. You can proceed. Yes, Mr. Abdul Nasir, you can continue your session. You can start your presentation, please. Sorry for the inconvenience, audience. May I request to Mr. Abdul Nasir, so please continue your presentation. Mr. Abdul Nasir, please, you can proceed. Sorry about the convenience of Mr. Abdul Nasir, so we can proceed further. We have a speaker who is a senior prosthesis and orthotist. Currently, he is working as an assistant manager in Physical Rehabilitation Center at Indus Hospital and Health Network. He has professional command on ICRC technology in lower and upper limbs. He is expert in designing of quadrilateral TSP and inner sockets. I would like to call Mr. Umair Sharif to present us brief introduction regarding the hydraulic pneumatic prosthetic joint, knee joint. Mr. Umair Sharif.
Privileged to be the part of Indus Icon 2022. Today, I am presenting the hydraulic and pneumatic prosthetic knee joints. First of all, what is the outline of our topic is prosthesis. What is prosthetic knee joints? Types of prosthetic knee joints, mobility grades, hydraulic knee joint, and in the last, pneumatic knee joints. First of all, what is prosthesis? It is an artificial device that replaces a missing part body which may be lost through trauma, disease, or a condition present at birth. Prosthesis can be created by hand or with computer-aided designing. Simple in short form, we can say CAD, a software interface that helps creators design and analyze the creation with computer-generated 2D and 3D graphics. Prosthetic knee joints are the component which replaces the anatomical knee joint. The technical capability of and performance of a knee prosthesis are instrumental in facilitating a walk that more closely resembles that of an able-bodied individual's biomechanics and thus increases amputee walking energy efficiency. Types of prosthetic knee joints. Prosthetic knee joints can be divided into mechanical and computerized. Mechanical knees can be subdivided into single axis and multi-axis polycentric knees. All prosthetic knee requires some sort of stability mechanism. This can be manual or a weight activated locking mechanism. Different knee joints used for different mobility grades or K levels. Knee joints mostly which are used are single axis knees, polycentric knees, manual locking knees, weight activated stance control, pneumatic and hydraulic knees, and computerized knees. What are mobility grids? Also known as K levels, they starts from 0 to 4. K0 level does not have the ability or potential to ambulate or transfer safely with or without assistance, and a process does not enhance quality of life or mobility. In simple words, we can say the bedridden patient is of K0 level. K1 level has the ability or potential to use a prosthesis for transfers or ambulation in level surfaces at a fixed cadence, typical of the limited and unlimited household ambulators. In simple words, K1 level is that in which patient is just using washrooms and doing such small works within the house. K2 levels has the ability or potential with the ability to transfer low level environmental waste such as scrubs, stairs, or uneven surfaces, typically of the limited community ambulator. In K2 level, we can say in simple words, the patient is going outside the house, doing their normal activities, but within the limited capacity. In K3 levels, has the ability or potential for ambulation with variable cadence, typical of the community ambulator who has the ability to transfer most environmental barriers and may have vocational, therapeutic, or exercise activities that demands prosthetic use beyond simple locomotion. In K3 level, in simple words, we can say the patient is doing normal activities of their living standards or in their normal life. K4 level has the ability or potential for prosthetic ambulation that exceeds basic ambulation skills, exhibiting high impact, stress, or energy levels, typical of the prosthetic demands of the child, active adult, or athlete. In K4 level, patient is just over the normal and doing little extra activities just like athletes and child amputations. Now, pneumatic or hydraulic knees. This is a pneumatic or hydraulic component. This is when a pneumatic or hydraulic component piston within cylinders containing air or fluid is added to single axis or polyaxial knees. These components control the swinging action of the prosthetic knee and allows the individual to vary speed. When speed is increased, the valve in the cylinders closes and gradually limits the airflow fluid to limit flexion of the knee. When knee flexion is reduced, the individual can walk at a faster pace. Advantage is the individual will be able to walk more comfortably at different walking speeds with a more natural gait. Weight can be kept on the prosthetic leg when sitting down and then when knee will assist the individual to sit down. The resistance in the knee, which will allow the individual to climb down a step, over a step when walking down stairs, when weight is kept on the leg before and during the motion. Less expensive and lighter than computerized knees. Disadvantages. Hydraulic knees are heavier, need more maintenance, have a higher initial cost when compared to manual knee joints. Now, now I am telling about this some hydraulic joints which are used commonly in our countries. First of all, 3R80 knee joint. It is the Autobock company which is from Germany based fabricated joint. The 3R80 with its unique rotation hydraulics principles can use with a body weight of up to 150 kg, about 330 pounds. With the 3R80, both the stance and the swing phase are controlled by the hydraulics. For example, walking down stairs, step over step, and walking down inclines are effectively supported by closely approximating a physiological gait pattern even at various walking speeds. These joints are used in K3 and K4 levels. Hydraulic 3R60 knee joint, this is also Autobot based joint. It is a polycentric knee joint, an intelligent miniature hydraulic system controls the pendulum movement of the lower prosthetic limb during the swing phase. Use up to weight about 120 kg. This joint is used for K3 levels. Now, pneumatic joint. This is also Autobot based joint, 3R92, commonly used in Pakistan, used for patient up to weight 125 kg. It stands out for its unique technology with an innovative load-dependent braking mechanism. A heavier heel load activates the brake. It stabilizes the prosthesis and ensure a high level of safety during the entire phase. This joint is used for K2 and K3 levels. This is also the type of pneumatic knee joint 3R78. This joint is also from Autobock company, Germany. The development of the 3R78 focused on robust dust resistance design that is durable and resistance against environmental impacts. This polycentric prosthetic knee joint with pneumatic swing phase control offers reliable stance phase, security for users up to weight 100 kg with moderate activity levels. This joint is used for K3 levels. Now, conclusion of the presentation or our topic is hydraulic and pneumatic knee joints used for K2 and K3 levels. These joints are cheaper than computerized knee joints. They need more maintenance, which is main disadvantages. Pneumatic knee joint is light in weight than hydraulic knee joint. Thank you.
Thank you very much, Mr. Umair Sharif. Now, I would like to call our next speaker, who is a prosthetist and orthotist, and also working at Indus Hospital and Health Network. He has full commands in recording measurements of orthotics and prosthetic devices. I would like to call Mr. Bilal Ahmed to share orthotic management in cerebral palsy patients. Mr. Bilal Ahmed.
Ahmed, I am a prosthetic and orthotist in Indus Hospital Physical Rehabilitation Center. Today, my topic of presentation is orthotic management in CTEV. First of all, we will know about what a CTEV is. It is a congenital telepo-equinovarus. Congenital telepo-equinovarus is also known as clubfoot. Clubfoot describes a range of foot abnormalities, usually present at birth, congenital, in which baby foot is twisted out of shape or position. In clubfoot, the tissues connecting the muscles to the bone tendon are shorter than the usual. Clubfoot is fairly common birth defect and is usually an isolated problem for an otherwise healthy newborn baby. It is congenital by birth deformity of foot in which the foot becomes plantar flex and medially rotate. It is the condition in which one foot or both feet point move downward and inward with sole of the foot facing backwards. It can be unilateral or bilateral. Normal angle of the foot is 70 to 75 degree. Abnormal angle of the foot is 40 to 45 degree. Causes of the CTV. There are some causes of the congenital telepoequinovirus or clubfoot. One is idiopathic. The other one is congenital by birth. Smoking during the pregnancy, intrauterine compression, the tissue that connects the muscle to the bone called tendon is in your baby legs and foot are shorter than the normal. Some classification of the clubfoot. Clubfoot is classified into three different types: idiopathic, neurogenic, and syndrome. Idiopathic is a known cause, neurogenic caused by the condition of the nervous system, syndromes related to an underlying syndrome. Common types of clubfoot. There are some common types of clubfoot. Talipes, whereas the foot is pointing inward and down. The most common form is the talipovarus and talipovalgus, where the foot points outward and down. Talipoequinus, where the foot points inward and up. Telipocalcaneus, where the foot points inward and down. These are the some images of the types of the clubfoot. Now we will go for further clinical features of the clubfoot or CTEV. Small foot with stiffness, small calf, tibia shortened, medial and the posterior foot skin creases, foot deformities. In this, hand foot is in equinus plus is in varus. Midfoot is in cavus and forefoot is in adduction. The treatment is based on the patient's condition. If CTV is unilateral and by birth, then there will be more stiffness of foot. So we'll move for surgery tenotomy. Tenotomy is the word is in which we use the needle to make small holes in the tendon through the skin to release the tendon. After surgery, there will be casting for 6 to 7 weeks. First, serial casting. That will be after surgery. If there is no surgery, then the initial there will be casting for 4 weeks. Further casting depends on stiffness. Casting used for to change the foot position along to provide the 90-degree structure. Then the doctor will change the casting after 15 days and before casting will change the foot position. After casting, we will go for the foot abduction orthosis. Foot abduction orthosis is also known as Dennis Brown shoes, splints, and also known as DB shoes. It consists of shoes mounted to the crossbar in position of 70-degree rotation and 15-degree dorsiflexion. Distance between shoes is set at about inch wider than the width of the infant shoulder. In unilateral cases, normal foot should in 40-degree or outward rotation. These are some pictures of the DB shoes. Now, CTV shoes are modified for the children who start walking. These shoes are used until 5 years of age. The special features are straight inliner border, outer shoes rise, no heel. Afterward, we will go for the A4's ankle foot orthosis, which are prescribed by the doctor if the correction is not possible. This is all of my presentation. Jazakallah. Thank you.
Thank you, Mr. Bilal Ahmed, for this detailed, informative session. And we will be right back after a short break. Please stay here. अच्छा भाई क्या Now, I would like to invite Ms. Mehwish Zakir, who is a prosthetist and orthotist and working in Indus Hospital and Health Network since 2018. She is skilled in making and fixing of fabricated devices. She will tell us about diagnosis and fabrications of transtibial prosthesis. Ms. Mehwish Zakir.
Assalamu alaikum. My name is Mehwish Zakir and I'm an orthoprosthetist in Indus Hospital. My topic for today, is socket designs and fabrication of transtibial prosthesis. My presentation layouts are introduction to transtibial prosthesis, socket designs and components, fabrication of prosthesis. Transtibial prosthesis. It is a mechanical device that replaces the limb at the level in between knee and ankle joint. Transtibial prosthesis. Basically, there are two types of transtibial prosthesis. One is modular and the other is the conventional prosthesis. Modular, as you can see, that it is easy to attach and disassemble the prosthesis, which is on the right side of the slide. Inside the prosthesis is the pylon tube. Components in transtibial prosthesis, there are basically four main components in modular prosthesis: soft end liner, sockets, prosthetic shin, which can be of many types, and prosthetic foot, socket adapters. Soft end liners. Soft end liners are of different types. It can be of silicone, gel, tapey foam, and it is usually wear before the socket, and it is the contact between the skin and the socket. So let's talk about the sockets. Socket is basically the main and the critical interface between the patient's body and the remaining prosthesis parts. Socket is the proximal component in the transtibial prosthesis, and it carries the shank and the foot. So I would like to discuss about the types of sockets. There are many types of sockets, and we decide that which type of socket should be given to the patient according to his medical condition and activity levels. There are of several types, but today I will discuss wooden type, PTB, which we call patellar tendon bearing socket, air cushion socket, heart socket, and KBM socket. Wooden socket is the ancient type of socket, which is usually created from the carve of the wood plank. It requires thigh corset for the better suspension of the prosthesis. It usually used to be open from the distal part and the remaining of the prosthesis attached from the walls of the socket. Patellar tendon bearing, which we call PTB sockets. They are most common type of prosthesis and the most common type of sockets. It can be made from the lamination and from the molded plastic to provide the intimate fit of the patient's body. The difference of these type of socket is of basically its walls. We usually used to keep its walls high for the better stability and better work of the patient. The reason why we keep its walls high is to make the stabilize is to stabilize the knee of the patient. Heart socket. Heart socket requires better venous return, and it usually used to give to those patients whose muscles and soft tissues are in good condition. In these type of sockets, soft inliners is eliminated. Now let's talk about the Shin components. There are two types of Shin components. One is exoskeleton and another is endoskeleton. Pylon tube. Pylon tube is basically the medium of the socket and the foot. It can be of stainless steel, titanium, and aluminum. We decide that what material is better for the patient according to his weight and age. Pylon allows easier transfer of patients from bed to chair. It connects the residual limb, which we can say in short that it connects the socket to the foot. And its length can be adjusted according to the height of the patient. Exoskeleton is also known as conventional type of prosthesis. The shank holds the foot ankle assembly in the fixed relationship. Space between the socket kept hollow. Only the outer shell is covered for the cosmetic appearance. It can be made up of petalene form, cork, and wooden material also. For ankle support, wood ankle block can be used also. Endoskeleton type. It is called the central support. The endoskeleton type is consist of metal tube, which we call pylon tube. It usually connects the foot and ankle. Outer covering is of soft form, which gives good shape, and it is also called modular type of prosthesis. Types of foot. There are two types of foot: jointless feet and jointed feet. So there are very large and huge category of foot, and most commonly type of foot we use for the patients is sach foot, which is called as solid ankle cushion heel. It has a heel cushion, and it's widely used in prosthetics, and it can easily be replaced. It is durable and low in cost. Dynamic plus foot. It returns the stored energy, which aids in propelling foot forward at toe off, and it is usually used for the active abulators, which fall in K3 level or above. Multi-axis foot. Multi-axis foot has multi-axial joint movements. It is movable in all directions. Recommended for individuals whose activity level is very moderate, and it can bear up to weight 85 to 187 lbs. Gersinger plus foot, used in moderate activity levels, acceptable for both lower and higher activity levels, secure standing and walking, good rollover properties, more natural gait pattern, and suitable for mobility grade 2 and 3. These are my references. Thank you.
For this detailed session about the diagnosis and fabrication of transtibial prosthesis. Now I would like to call Mr. Abdul Nasir. Please have a detailed sessions on the prosthesis management. Mr. Abdul Nasir, who is a senior prosthetist and orthotist. Currently, he is working as an assistant. Please, Mr. Abdul Nasir. Sorry for the inconvenience, audience. I think there is some kind of connectivity issue with the Abdul Nasir. He will be right back in a short time. For that time of period, can start our question and answer sessions. And if anyone from you have any question from any one of our speaker, feel free to ask. You can ask any question with one of our speaker from the audience. If you people have any kind of question, so you can ask. Yes, Bilal, do you want to say something? Anybody who can ask any question with one of our speaker, feel free to ask. I hope this session will help you to gain some knowledge regarding different perspective, physiotherapy management with the orthotics and prosthetic management in the physical rehabilitation centers.
Gulzaman.
I think we are now connected with Mr. Abdul Nasir and Gul Zaman Saab. So I would like to call Mr. Gul Zaman. Please come and have a detailed guide us about the multidisciplinary team role in physical rehabilitation. Mr. Gul Zaman. Mr. Gul Zaman, can you hear me?
Um, can I ask a question?
Yes, sure. You can ask. If you have any
Qasim, I
question.
want to ask a question about the role of physiotherapy in COVID-19. So, what do you think? There is any role in post-COVID sequelae? The role of physiotherapy or pulmonary rehabilitation? Have you seen results with post-COVID sequelae?
Sorry, I didn't hear you properly. Can you repeat your question?
जी जी
Yes. I ask, is there any
टेस्ट होगा
indications
आपका
or
फेयर क्यों टेस्ट होगा
effectivity for pulmonary rehabilitation in post-COVID sequelae?
Yes, we are working with the
Hello.
post-COVID patients in our pulmonary rehabilitation setup. All the patients are getting treatment under the pulmonary rehab program. After getting discharged from the hospital setup, we enroll them, the post-COVID patients, in the pulmonary rehabilitation programs and taught them all kinds of exercises, including the chest physiotherapy, including upper and lower limb strengthening exercises, and that leads to the most functional activities, including the cycling, bicycling, jamming. That depends on the
Okay.
several days and weeks.
Okay. Thank you. Thank you so much. Thank you.
Welcome.
Now
You're welcome.
Gulzaman can start. Thank you.
Now, Mr. Gulzaman, you can proceed your presentation. Mr. Gulzaman, please, you can start. Yes, Mr. Gulzaman, please, you can start. Mr. Gulzaman, can you hear me? Yes, Mr. Gulzaman. Yes, Mr. Gulzaman, we can't hear you properly. Mr. Gulzaman, can you please speak? We can't hear you. Can you please start? No, I think there is still some kind of hearing issues, and we can't hear you properly. Your voice is not. Your voice is interrupting. Please remove your headphone so the voice will come easily, I think. Then try to speak up. Now, now you can speak. Yes, I hear you. Yes, you can speak up. No, no, no. Can't hear you. Yes, Mr. Gulzaman. No, we are not getting your voice. I think there is still some kind of connectivity issues or your voice is interrupting. I'm extremely sorry for this inconvenience to our all audience. If anyone have any kind of question, feel free to ask. Mr. Gulzaman, can you hear me? Mr. Gulzaman, yes. Can you speak something, please? Sorry, Mr. Gulzaman, I think there is still some kind of connectivity issue from inside. So we can proceed to the our last step and coming for the vote of the thanks. On behalf of Head of Physiotherapy Department, Ms. Farah, and Director Rehabilitation, Professor Dr. Mohammad Amin Chunai, I would like to thank all the wonderful peoples who spoke in today's sessions. All of you taking time out for your busy and personal and professional schedule means a lot to us. I would like to thank all of the participants too. Once again, thank you very much. Dr. Farooq Azam Rathore from our Institute of Rehabilitation Medicine, Rawalpindi, for your precious time in contributing in our icon, and all the other speakers. Once again, thank you, students, volunteers, all the programs who organized this wonderful session. Thank you very much for being with us.